Assalamualaikum. My name is Dr. Zoha. I'm a resident of urology, and today I'm going to be presenting the second part of basics of endourology. Which today the topic of my presentation would include percutaneous tubes, double J stents, and intracorporeal methods. So first, we're going to talk about percutaneous drainage. So the indications of percutaneous tubes would be there are four broad indications, which are relief of urinary obstruction, diagnostic testing, urinary diversion, and access for therapeutic intervention. In simple drainage, percutaneous renal drainage is effective for most, if not all, obstructions, including those in intrarenal, ureteropelvic junction, or ureteral indication. For therapeutic intervention to facilitate, it is used to facilitate installations of chemotherapeutic agents for upper tract urothelial lesions or agents for chemolysis or renal stones, foreign body removal, stone removal, or tumor functions. For diagnostic studies, there is Whitaker test, in which it is used to study to differentiate obstructive from non-obstructing hydronephrosis. After obtaining percutaneous access into the kidney, the upper urinary tract is perfused at a constant rate and pressures are transduced in the renal pelvis and urinary bladder. The finding of pressure differential above 12 centimeter water across the ureteropelvic junction or ureter indicates urinary obstruction. It is also used as a diagnostic study for APT. Percutaneous renal surgery. Percutaneous renal access facilitates surgery for upper tract calculi, urothelial tumors, obstruction, and colical diverticuli and hydrocephalus. Contraindication for percutaneous drainage would be uncontrolled bleeding diathesis, uncooperative patient, and severe respiratory distress. An ideal nephrostomy tube should
So,
be
who will summarize what is the indication of PCM? जल्दी से कोई बता दो. Uh, what therapeutic procedure you will do?
Mostly chemotherapy medications are
In others, any other procedure you can do with anti-care.
yeah, we have other option that we can do the situation critical test with the to just see the obstructive and non-obstructive.
PU0 में कुछ करते हैं कभी PU0 में एंटीग्रेट आपने अच्छा बताया. गुड. एंटीग्रेट पहले पीसीएम करते हैं उसके बाद फिर हमें अगर सपोज we have done pyeloplasty and then we have done the PCM and there is an obstruction in the partial obstruction in the at the PU0. Then we have to perform a procedure to integrate. तो अब वो क्या करें अगर पाइलोप्लास्टी चले जाए तो क्या करना होता है एंडोपाइलोट. So we can do the endopilot if you integrate it. ठीक है. अरे चल
That has to be done in drone position and from the if it is your performing retrograde. So अब इसमें एक क्वेश्चन आता है कि where will you give incision if there is PU0? You go for integrate by integrate retrograde endopilotomy, and where will be your incision given in a clock? 12 o'clock is up, 6 o'clock is down, 3 o'clock is on the right, and 5 o'clock is 9 o'clock. Where will you start using cutting that area? कहीं से भी कट कर देंगे और सुराख कर देंगे.
or up to what extent you have to give the incision.
Yes.
It is important.
These are very important steps because this will be very important in the practical life as well as from the theoretical point of view. It will be asked in MCQs, it will be asked in round plays, short plays. Scores. You have to understand the basics. Where are the vessels? Where are the vessels? Vessels are on the 3 o'clock or 12 o'clock on that side. So you have to cut opposite that. Okay, what is the principle behind it? You have to cut to that extent what Dr. Tanzil said. He was giving you a hint, but you people are not picking it up. He's regularly giving you hints, but you are not picking it up. That you have to cut to that extent that you have to see periurethral fat. ये जो हमारा डर है ना वो वहाँ पूरा करना होता है, काट दें पूरा, सुराख कर दें गाइड वाइड डाल के, तो पूरा लैटरली उसको कट कर दें पूरा, एंड देन यू हैव टू परफॉर्म अ रिट्रोग्रेड स्टडी एंड चेक दैट वहाँ एक्स्ट्रा विजिट हो रहा है. यू हैव टू मेक एन इंटेंशनल एक्स्ट्रा विजिशन इन अ केस लाइक दैट. पेरीयूरेट्रिक फैट तक उसको कट करना है, वरना दैट वोंट बी अ सक्सेसफुल.
हारिस भाई ने बताया कि आप जो है उसके बाद जब आप व्हेन यू डू द एंडोपाइलोटमी देन यू हैव टू डू द रेट्रोग्रेड एंड इफ देयर इज एक्स्ट्रा वेजिटेशन देन दैट इज द गुड endopilotomy and this shows that we have done a good incision at the PUJ.
सॉरी जरा आ गया दिमाग. तो उसके बाद एंडोपाइलोटमी करती फिर क्या करेंगे? गाइड वाइड डाल के छोड़ के आ जाएंगे या डीजे डालेंगे?
कमल है.
जी, सवाल मेरा है आपसे कि यू हैव परफॉर्म्ड एन एंडोपाइलोटमी वेरी सक्सेसफुली. यू प्लेस्ड retrograde contrast extravasated. Now what will you do?
Yes, a digestion.
Degestant, whatever. Adult patient with normal height and weight.
4 or 6 FR, 6 FR.
ये जो आपने सवाल किया ना एग्जाम में कि कौन सा डीजे है कुछ, this shows that you are not picking up my. ठीक है. Where is it? Where is this written that you will place a 6 FR in an average height and weight patient? So the examiner knows and he tests you with knowledge. I tested you with knowledge and I know that you don't know. So I'm not just pointing out one person, I'm just telling you the psyche of an examiner. He tests you, you reply, he becomes happy or he becomes angry. सही है. तो इसमें एक चीज होती है एंडोपाइलोटमी स्टेंट. किसी को एंडोपाइलोटमी स्टेंट के बारे में बताइए, खवातीनों हजरात में से किसी को.
5 upper end for the drainage.
What wide? मतलब 50 FR. Endopilotomy stent is 14 FR at the top and 7 FR at the lower part. So to coop up that, if you don't have an endopilotomy stent, over here we place 2 7 6 FR DJ stents, which gives us 12 to 14 FR upper that area which you have cut remains open and the main function is being cleared. एक और कॉन्सेप्ट पाइलोप्लास्टी का गलत है कि everyone will perform pyeloplasty, everyone comes with an ultrasound. Sir, after pyeloplasty there is hydronephrosis. That hydronephrosis for 20 years that will remain over there. That patient needs the follow-up on MAG3 scan. कि उसकी functional obstruction है या नहीं है, पानी तो उसमें रहना ही रहना है. So read about these topics. This is your long case, and please start reading because these are the basics. So class every.
और पाइलोप्लास्टी के बाद जब मैक थ्री स्कैन कब कराएंगे, व्हेन विल परफॉर्म द मैक थ्री, समझ जल्दी से बता.
6 to 8 weeks.
ऑल टू
तो प्राइवेट में मैक स्कैन कर रहा होगा वो अमीर हो जाएगा काफी. ये इन लोगों का होमवर्क है. सही, आप लोगों का होमवर्क है. In the next meeting, we'll ask, maybe it will be tumor board. In the end, at 9 o'clock, we'll ask you the question.
An ideal nephrostomy tube should be biocompatible, easy to insert. It should give good flow, resist infection, infestation, distortment, and does not induce symptoms. Types of percutaneous tubes. After percutaneous renal access and surgery, the surgeon must consider what, if any, means of drainage to employ. So the types of percutaneous tubes are there is balloon catheter, Malacor, Coke catheter, nephroureteral stent, and Serval catheter. For balloon catheter, it is used for transurethral drainage and used as nephrostomy tubes as well. 16 to 24 French catheters are used for post-operative nephrostomy drainage. It has an ability to pass a small caliber catheter through the end hole and down the ureter, giving access to the upper urinary tract, maintaining ureteral frequency. A cope catheter is more secure, has a more secure retention mechanism. A string exits the catheter a few centimeters from the distal tip and then re-enters the catheter near the tip, as you can see in the picture. Pulling on the string forms a secure coil that is not easily dislodged from the renal surface. The string is fixed at the external end of the tube with a locking mechanism. It ranges from 16 to 14 FR in diameter. It can be used for simple upper urinary tract drainage and installation procedures and after percutaneous surgery. The Malicot catheter has wings that expand when the catheter is at rest, providing a modest but atraumatic and non-obstructive retention mechanism. The Malicot catheter for renal use are large bore catheters ranging from 16 to 30 French. Then we have the nephroureteral stent. It has the same mechanism as the cope catheter. A nephroureteral stent has a renal coil like that of a cope nephrostomy tube, but the tube continues to a ureteral extension that travels down the ureter to end in a passive pigtail that rests in the bladder. A nephroureteral stent is passed percutaneously over a wire that ends in the bladder. Once the end is coiled, generously in the bladder, careful inspection of the fluoroscopy image reveals the location of the side holes in the renal coil. A nephroureteral stent offers excellent control of the entire upper urinary tract from renal pelvis to bladder and is unlikely to become dislodged. Nephroureteral stents are available in diameters of 8 to 12 French and the standard lengths from renal to bladder coil are 20 to 28 centimeters.
This passes from the kidney to the bladder.
Yes.
So what is the difference between this stent and a DJ stent? This is the DJ stent.
No, sir. This is the percutaneous tube.
What is it?
This basically passes antegradely into the kidney. First, we puncture the kidney. We enter this from through the kidney, and the DJ we pass from retrogradely from bladder.
This is a mechanism. I'm not saying this catheter, but this is the mechanism that there is some malignant obstruction we see in a lot of patients. The mechanism is that in those patients there is complete fibrosis because of malignancy, complete compression, or maybe there is non-malignant fibrosis as fibrosis. In those cases, we don't, but usually people, what they tried was they placed a stent from kidney to the bladder through a submucosal channel, not through the normal passage, but from the submucosal channel. So that was a way to keep the patient 3 monthly change of DJ and things like that. And in those patients, it was difficult to pass them. They were on PCNs. So this is the mechanism for fixing that as well. This is the
So we also have the circle catheter, which is secure, easily exchanged. It causes little trauma, rarely occludes, and provides excellent drainage and an avenue for irrigation of the renal pelvis. The circle nephrostomy tube requires two percutaneous access sites to the kidney, and this tube is mostly useful when maintenance of two tracts is desired. Complications of percutaneous
more catheter metallic stents can be used as well. Have you heard, anybody has heard about metallic stents? Yes, yes. चलिए discuss करेंगे. अच्छा, आएगा.
The complications of this can be acute hemorrhage, delayed hemorrhage, collecting system injury, distal injury, pleural injury, metabolic and physiological complications, post-operative fever and sepsis, venous thromboembolism, tube dislodgement, collecting system obstruction, and loss of renal function. So, percutaneous nephrostomy that we see every day. The equipment includes this LP needle, And then there's this PCN tube itself. We have the dilator set, the syringe, the connecting tube, a blade, guide wire, and dressing. This is a small video to illustrate
एक और
how a
चीज भी चाहिए
percutaneous
थी जो उस पर नहीं थी और हम करते भी नहीं है, तो वो कौन सा सोल्यूशन है जो चाहिए और हम जो करना चाहिए, कुछ मिसिंग है इसमें, कोई बता सकता है?
Pyodine.
सर स्टिच मिसिंग है
नहीं कुछ
सर, स्विचर नहीं है, स्विचर मिसिंग है
नहीं, इसमें जो है वो
Arsalan, maybe this is a self-retaining catheter.
इसमें PCN के दौरान अभी हम देखेंगे कि जब when you have to puncture the kidney and you are not sure, या you are sure, then you have to pass 2 to 3 ml of contrast into the kidney to opacify the pelvic cholecyst system, and this is mandatory. If you want to minimize the complication, then you have to do the you have to instill the contrast into the pelvic cholecyst, and you are sure that you have passed the PCN through a dialysis.
And there are two types of PCN. One is ultrasound, and the other one is fluoroscopic guided puncture as well. You place a fine needle into the kidney, and you check it on the ultrasound that it is in the kidney. There's no. This is done in patients who don't have a very gross hydronephrosis, very mild minimal fullness. Place that, and then you place that contrast, the kidney highlights. Then you fix on the fluoroscope, and then like CNL, you puncture the kidney, and then you place a tube. So that is a fluoroscopic.
Okay, so this patient's got a nicely dilated pelvic heliceal system with some atrophy of lower pole cortex. We're just going to try and enter the cortex just above, calyx just above, and we're putting in a large bore 12 French nephrostomy tube for long-term drainage for presumed infection. So we're just going to put some local anesthetic in, so there'll be a sharp scratch and a little bit of a sting, okay? Just making a small little nip. Okay, so this is an 18 gauge diamond tip non-cutting needle, which tends to use for nephrostomies. It's very rigid, doesn't bend very much, and goes exactly where you want it to. It's easily visible on ultrasound. Bit of pushing now. So just decompressing the system slightly before we add any contrast that minimises the chances of any bacteremia. I'm going to inject neat contrast because it's a dilated system, so the contrast is going to be diluted immediately. See it going free into the cleansing system. Okay, so I'm just putting in a Benson soft floppy tip guide wire, which we're then going to change for a stiffer wire so we can dilate the tract slightly to put in the larger bore nephrostomy tube. And it's a Compe catheter which has a short angled tip, a little bit like a biliary manipulation catheter. Just going to insert this so that we can then steer the guide wire into the renal pelvis. Okay, so the guide wire has been manipulated down into the renal pelvis and the upper parts of the ureter with this angled catheter. Okay, so just injecting a little bit more contrast just to confirm the position within the renal pelvis. Now just putting in an extra stiff guide wire, which will give us more support to dilate the tract. So just putting on an 8 French dilator just to start dilatation of the tract. This is a 12 French nephrostomy we're going to finally put in. Just rotating the dilator in. Okay, so 10 French dilator. Right, it's a Cook 12 French locking pigtail catheter, large lumen, multiple side holes, can be inserted using either a central metal stiffener or using a plastic stiffener, which is just there, which allows a lot more flexibility. So once the tip of the catheter is into the collecting system, we can unlock the metal stiffener and slide the catheter over the wire. That will coil up within the renal pelvis. Okay, so now we're in position, we can lock the pigtail catheter by pulling the thread through, rotating it around a couple of times, and then pushing it flat. And that clamps it into place. We then can fully decompress the system. Okay, we'll just put a bung onto the end of the catheter just for a few seconds whilst we put the flange on. And we leave these catheters in a bag with a flange, which means they're easier to manage and they're much less likely to be inadvertently pulled out. Even with a locking mechanism, these catheters can actually be pulled out by accident. We just place the end of the tube through the valve in the bag. It's just clipped into place.
This was a very excellent presentation of how to perform a PCN, but in the end there was slight bleeding. So if that is the case, you can call your senior and don't carry on that Dr. Zoha has shown us a video that this is very normal.
So briefly explaining, the steps of percutaneous nephrostomy would be, first we'll position the patient as you saw in the video. There will be surface marking, ultrasound to decide site of percutaneous puncture. Then as the video illustrated the puncture technique, there was guide wire insert. We will insert the guide wire. There will be tract dilatation and insertion of nephrostomy tube over guide wire. I'll just skim through. Moving on to double J stent, the second topic of our presentation. It is a hollow tube with a coil at each end inserted to the bladder into the ureter, then into the renal pelvis. It is designed to bypass a ureteric obstruction and drain the kidney. Having a coil at each end, it prevents it from migration. Its classification is based on length, material, and size. Classification of on length would be, length of stent is the straight part of the stent, not from tip to tip. In pediatric age, the formula of measuring length of DJ to be used is H plus 10 centimeter. In adults with height of 149 to 179 centimeter, length of DJ used varies from 22 to 26 centimeter. Ways of measuring length of DJ, which I found was on X-ray KUB, length is decided by measuring length from xiphisternum to pubic symphysis, and on IVU, distance between PUJ and VUJ would be the length of DJ stent. Classification on basis of size would be it is measured at the shaft. It represents the outer diameter of stent, usually measures from 3 to 8 French. On basis of materials, a DJ stent can be polymers, made of polymers, metallic, or can be biodegradable. Polymers usually used are polyuroethane, silicon, C-flex, Soflex, and Percuflex. Polyuroethane in polymers has good tensile strength. It doesn't compress on extrinsic compression. There is rigidity its rigidity causes more stent-related discomfort and ureteric damage. A silicone stent is highly biodurable. It has high biodurability but has poor tensile strength and susceptible to extrinsic compression. Percuflex, Soflex, and C-flex are made of proprietary copolymers, softer and lesser bladder irritation. They are more biocompatible and can be left inside for a longer time. A metallic stent is not hollow and is a solid cylindrical stent. It is for extrinsic ureteric compressions and can be left in place for more than 12 months due to its low incrustation potential. A mammocath, which is also a type of metallic stent, it expands to predetermined size at warm water, 60 degrees centigrade. It is resistant to incrustation. It is used mostly for variable length of strictures, benign and miscellaneous stents. There are two types of stents. One is dangler and the other is endopilotomy stent, which Sir just mentioned before. Dangler stent is a usual DJ with added nylon or proline bore loops dangling outside the stent end, helpful in removing without cystoscope. An endopilotomy stent after endopilotomy or endourology of upper ureter or PUJ, proximal end is wide with narrow distal end. Contraindication of DJ stent is uncontrolled bleeding diathesis and untreated symptomatic urinary tract infection. This is a small video, basic, to show how DJ is inserted.
Your doctor has recommended to insert a stent between your kidney and your bladder. The medical term for this is a double J stent. The stent allows drainage of urine from the kidney into the bladder by temporarily relieving any blockage caused by a stone in the ureter or an internal swelling out the ureter. The renal pelvis is the area where the kidney attaches to one of the ureters. Urine flows from the kidney through the ureters into the bladder. When emptying your bladder, the urethra transports the urine from the bladder to the outside of the body. This animation shows the ureter caused by a stone. Urine is unable to flow from the kidney to the bladder, causing congestion and sometimes pain. The procedure is usually done under general anesthesia. A tube with a tiny optic camera is inserted through the urethra into your bladder. The inspected and the ureteric opening is located. A contrast study may be performed to assess the urinary tract and to locate the obstruction. X-ray images can now clearly outline the ureter and the obstruction. A so-called guide wire is introduced through the camera into the kidney. The double J stent is in this guide wire. J-shaped curls are present at both ends of the stent to hold the tube in place. X-ray is used to check that both ends are in place in the kidney and the bladder. The stent is later on removed or is sometimes used as a temporary intervention before the stone with another procedure. You will be discharged from the hospital when you have been able to empty your bladder sufficiently and you have no fever or other complaints.
As you saw in the video, every procedure has complications as well. So the complications and consequences of ureteral stent placement can be, it can cause irritative voiding symptoms, it can cause incontinence, suprapubic or flank pain, vesico-renal reflux, hematuria, pyuria, urinary tract infection. It can get malposition, it can migrate, it has there could be inadequate relief of obstruction, it can get incrustate, there could be ureteral erosion or fistulization, the DJ could fracture, or there could be a forgotten DJ.
So incrustation is a very big problem of our patients. So how can we minimize this incrustation in the patient? किस तरह हम minimize कर सकते हैं? सर भी बैठे हैं प्लीज. तो ये बहुत बड़ा प्रॉब्लम है सर. हमारे पास incrusted डीजे आते हैं तो फिर हम उसको किस तरह सॉफ्टवेयर बनाएं या कुछ करें.
हाँ, मेरे तो ख्याल में यही. There was discussion on this forgotten DJ and incrustation both in EAU. So they were discussing the ways and means how to reduce this or how to avoid this. So one suggestion was this: you create any program or software and register that name, and then we have started twice, thrice at OT and in Euro 2 that Sarah, social officer, she used to put these all names in computer, and they used to call them, these patients, and ask them whether your stent has been removed or not, because these problems occurs after 3 months, but nowadays maybe 2 months and 3 months because of, I think, quality of material. So I think this is the way we should call them and ask them, is it removed or not? And second, when patient is coming for follow-up in OPD, we should tell them as well that this should be removed within 3 months. And If it is forgotten, then there will be problems with incrustation and many things. So these both ways I think will work. We should enter these all names whenever we put DJ stent, and then we call them. Every day we should see that if 2 months are passed, then we should call them and ask for removal of DJ. And I think that is the proper way. I think so. Maybe there are other ideas.
The bottom line is the onus lies on the surgeon who has performed that surgery and placed that DJ to remove that DJ somehow. We had a very long discussion on Twitter as well that how people in UK, USA do that. One of the surgeons, they said that we write a letter, we call them, we write a letter to them, and if we have to send somebody to their home, we send them that DJ needs to be a serious problem. And at our setup, what the problem is, there is a bit of lack of communication. A lot of patients come, they say, we don't know that we had a stent. And this should not happen in this era. So there should be communication. The person who has placed that DJ stent should talk to the attendants, talk to the patient that this tube has to be removed. Yesterday, we placed a lot of DJ stents, and there was a young boy who got a DJ stent, and the family not that much literate and all. And but the father of that child understood that there is a tube placed. I explained him, and I gave emphasis that you have to get that tube out after 4 weeks. So there is a bit of lack of communication as well. Those who are discharging the patient from HDU, from the theater, they have to call the attendants and tell the patient that there is a tube placed, you have to remove them. But then the patient comes for follow-up in OPD at our clinic. Then also we have to emphasize that you have to get that tube removed. If it is a simple case, you can give a date and explain them. So things like that can be done. I feel that at our setup, there is a bit of lack of communication as well. आगे वो फिर financial issues and patient couldn't come, that is something else. But we should start. Then, as Professor MD said, that there should be some mechanism to call those patients.
When we discharge them, we should talk to family and patient both, and we should tell them that there is a inside and this should be removed within 3 months. Otherwise, there will be problems with incrustation, stone formations, and then maybe big surgeries. So one thing is, I think, whenever we discharge them, we should tell them. And second is that these all should be registered in one program, and periodically we call them. And I think third thing, maybe I think possible, practical or not, we should make a small card written in Urdu and Sindhi, both languages, that there is a tube inside your body in kidney and ureter, bladder, and this must be removed within 3 months. Otherwise, so अगर ये हम कर सकते हैं तो हम पॉसिबल अगर है ओटी में हम दे सकें पेशेंट्स को, वो एक अलग कार्ड बना सकते हैं, हम प्रिंट करवा सकते हैं, और वो भी हम साथ में दे दें डिस्चार्ज कार्ड के साथ कि भाई ये है, क्योंकि वो फिर खुद भी पढ़ेंगे, खुद नहीं पढ़ सकते तो पढ़वाएंगे. तो ये चीजें हम कर सकते हैं जो डिफरेंट मैन्यूवर्स हैं टू अवॉइड दीज प्रॉब्लम्स.
Can anyone from the audience tell what is wrong in these pictures? What happened to the DJ?
On the when on the one side it is showing the distal end of the DJ is encrusted with the stones, and on the second side there was a broken DJ in the both kidneys and in the bladder loop, in the bladder as well, and it is also showing some incrustation around the DJ loop.
Yes. What about this?
Distal loop of the DJ is not completely found in the bladder on the right side. Maybe it is migrated or displaced.
The malposition or migration.
And above, I think this is malplacement.
Okay.
most of the time.
So
Now, this is the distal ureteric stone and there is a hydronephrotic kidney. And patient is okay. Uh, there is a mild hydronephrosis hydroureter. So, should we place PCN or DJ stand or directly we will go for URS? Kamal, batao. Patient did not have any symptom, only flank pain, and there is no fever. TLC is normal, platelets is normal,
No
urine culture is normal.
non-comorbid. No
Yes.
non-comorbid. Then we will go for the definitive treatment if
Yes.
there is.
Yes. So it depends upon the symptoms of the patient and condition of the patient, whether we have to divert or whether we have to go for definitive procedure.
Internal echoes. And if there are echoes, then I think better way will be to divert first by percutaneous nephrostomy and then go for definitive procedure.
Now, this patient comes with a ureteric stone and there is a moderate hydronephrosis in the kidney, and kidney is looking good, 10 centimeter kidney. And patient having fever, TLC increase, then what we do? Should we pass the DJ stand or PCN? Internal echoes is there.
No doubt, definitely we should proceed for the PCN in this case. And I think the stone bulk is larger in this, and there will be some difficulty in negotiation. And also we can't proceed with this high raised TLC count and echoes in the system by registered.
We have to pass the PCN in it. In this case, if the scenario is like that, that there's an internal echoes in the kidney and TLC is raised and the patient having fever, so we'll pass the PCN. Then we'll give the antibiotic for some days, and we have to do the culture from the PCN. And then, if the patient is settled after 10 to 14 days, then we'll do the definitive procedure after doing some investigation, other investigation. तो इसमें ये होता है कि ये सिम्टम डिपेंडेंट होता है कि आपने क्या करना है पेशेंट को ना. सपोज अगर ये पेशेंट, अगला पेशेंट दिखाएं. This patient is there. There is a obstructing stone in the proximal ureter, and the kidney is grossly hydronephrotic, and there is internal echoes, and patient is having fever. तो इसमें अब इसमें जो है वो हमें क्या करना चाहिए? कोई और बताए? खालिद क्या? अच्छा, PCN किया और उसमें 200 ml आउटपुट आ रहा है. अब क्या करेंगे? आगे कुछ डेफिनेटिव करेंगे या नहीं करेंगे?
इसके बाद मैक 3 पहले करवाएंगे सर.
तो वो कब कराएंगे? यही मैं पूछना चाह रहा हूँ कि आपने PCN कर दिया, फौरन मैक 3 करा लेंगे?
नहीं सर, 2 to 3 वीक्स के बाद करवा देंगे.
4 to 6 weeks. 4 to 6 weeks के बाद आप मैक कराएं. या एक और चीज भी होती है, जैसे सिंगल किडनी का हम जो है फंक्शन बता देते हैं.
24-hour creatinine.
Yes, we can do the 24-hour creatinine clearance from the PCN. And if it is less than 15, then obviously it is not working kidney. And if it is more than 15, then we have to think about that. So we can do the MAC3 scan after 4 to 6 weeks, and we can do the 24-hour creatinine clearance from the PCN to document that whether kidney is functioning or not functioning. Agla kuch. Now this is the CT scan shows that there is a obstructing stone and patient having right flank pain and good cortex on the right side. And there is a supposed 2.5 centimeter stone and there is no internal echoes. अब क्या करेंगे नौमान? और पेशेंट का रीनल फेलियर भी नहीं है. मैं इसलिए बताना चाह रहा हूँ कि ये सारे सिम्टम डिपेंडेंट और पेशेंट के सिनेरियो डिपेंडेंट होते हैं. हर पेशेंट को डीजे नहीं डाला जाता और हर पेशेंट को पीसीएन नहीं किया जाता. तो इसको अगर इस तरह लेंगे तो फिर हम ज्यादा अच्छा मैनेज कर सकेंगे. तो पेशेंट हैविंग राइट proximal ureteric stone and there is a moderate hydronephrosis in the kidney and the kidney cortex is good. The kidney is about 10 centimeter and patient having symptoms of 3 to 4 weeks and there is no fever, TLC is not raised. And what should we do? in this case 2.5 centimeter का stone है.
This case, the patient having moderate hydronephrosis, if we can, and the renal function are within normal limits, we can do the PCN.
Should we divert or not?
We should go for in our scenario, because we are having a lot.
No, we are in an ideal scenario.
In ideal scenario,
Yes.
we are having a lot of things in our armamentarium. We can go for direct definitive procedure, robotic or laparoscopic or other ureterolithotomy, because stone size is about 2.5 centimeter. In other case, we can also give the patient the internal drainage with by passing the digestant, and this is a proximal uteric stone. We can pass the digestant, push back the stone, then do the PCNL, or we can push past the digestant and go for the on the depends upon the hospital unit of the stone. We can do the lithotripsy proximal uteric stone. But the stone bulk is, you are saying it is about 2.5 centimeter. So we should go for the laparoscopic or
Robotic ureterolithotomy, yes. So stone size is very big, and it is obstructing stone. So we cannot do the lithotripsy in this patient. We can do the robotic ureterolithotomy, and if we can able that, we can do the minimal invasive technique like mini PCNL and like that. Sir, आपका क्या ख्याल है?
the other kidney is also having
Narrowing वगैरह तो नहीं लगी?
Maybe this patient has structural narrowing below the stone as well. So इसको भी हमें then we should
Address करना चाहिए.
address करना चाहिए, क्योंकि ureter is little irregular, wall is irregular, and it's dilated for I think 2-3 centimeters below the stone, and maybe there is something else at that point where there is, and then you can see that down that point, ureter is normal, it's not dilated, but 2-3 centimeters.
in case.
So maybe there is some structure, or we should also see that as in by retrograde study.
In the case when we are suspecting distal ureteric stricture or narrowing, and the hydroureter above and below the stone, if this is a scenario, then we should put the percutaneous drainage to do the antegrade, and under GA we should do the retrograde, so that we can assess the distal ureter also. That either it is a stricture or there is some other pathology lying down there.
You are right, Noman.
The third part of our presentation includes intracorporeal lithotripsy. There are 4 techniques: electrohydraulic, laser, ultrasonic, and ballistic lithotripsy. The 5th type would be dual. This chart very briefly summarizes the properties, mechanism of action, advantages and disadvantages of all the type of intracorporeal lithotripsies. First, we have.
What do you mean by intracorporeal lithotripsy? मिसाल बता दो. Intracorporeal lithotripsy. With the help of
like ESWL is a type of intracorporeal lithotripsy.
intracorporeal. External.
Sorry, sir. Intracorporeal means that we are going inside the body through some instruments to break the stones.
Yes. With the help of URS, with the help of scoop, with the help of anything. Okay. So intracorporeal means inside the body.
Inside the body.
Okay. Sure.
And ESWL is
Extracorporeal. Extracorporeal.
So first we have electrohydraulic lithotripsy. It can be used all for bladder, in the bladder, ureter, kidney. It can be used with a flexible scope. First, I'll tell you the mechanism of action so you can understand why contact of 1 millimeter from the stone is important. The electrical spark produces a vapor bubble and subsequent cavitation bubble creates shock wave that fractures the stone. So for the bubble that creates shock wave, the stone distance from the instrument should be 1 millimeter at least. Tissue effects for more than 1 millimeter distance from the mucosa, less than 500 millijoules, or there is no injury. For more than 1000, there's ureteric perforation can occur. Advantage of electrohydraulic is that it is able to reach the lower pole. It is inexpensive. The disadvantages include there is significant tissue damage at high energy and the durability of probe tip. There is durability of probe tip. The probe sizes are 1.6, 1.9, 3.3, and 9.
अल्ट्रासोनिक आपने कहाँ देखा है? कहीं देखा है इंट्राकॉर्पोरियल लिथोट्रिप्सी करते हुए अल्ट्रासोनिक? कोई बता तो, खालिद आपने देखा कहीं? पीसीएल नहीं देखा? पीसीएल में करते हैं ना अल्ट्रासोनिक प्रोब होता है, ठीक है।
The second is ultrasonic. It is also used for kidney, ureter, and bladder. There should be direct contact with the stone. It is the mechanism of action. Is that there is a rapidly vibrating probe tip that results in fragmentation while simultaneously aspiration and removes the debris. Tissue effect would be there is mucosal stripping. There is no muscularis damage. Advantage is that it is most efficient single modality, inline suction for simultaneous stone removal. Disadvantages of this is intracorporeal lithotripsy is that there is reduced efficiency in hard stones. The probe sizes are 2.5, 3, 4.5, and 9. Pneumatic lithotripsy is also used for kidney, ureter, and bladder. It cannot be used with flexible. There should be direct contact. The ballistic tip repeatedly strikes stone similar to jackhammer. Focal areas of hemorrhage and mucosal erosions can occur. Least traumatic of all the intracorporeal lithotripters. Advantage is that it is least traumatic, works well on harder stone, it is least expensive, and but the disadvantage is least efficient and there is significant retropulsion. Probe sizes vary from 2.4, 3, 4.8, 6, and 10.5.
रेट्रोपल्जन का क्या मतलब होता है? What do you mean by रेट्रोपल्जन?
No.
Yes, stone can migrate into the kidney.
Yes.
So there is a difficulty to do the URS in the kidney because we are doing the semi-rigid URS. So yes, with semi-rigid URS and pneumatic lithoclast, you cannot go into the kidney. There is a migration, then we have to pass the DJ stand and then we have to do the lithotripsy.
रेट्रोपल्शन को अवॉइड कर सकते हैं नहीं ड्यूरिंग प्रोसीजर?
से कर सकते हैं।
Ways to avoid the retropulsion. As
Kamal.
well as it depends on the stone. The stone is located if in the distal ureter and that the good control of water or normal saline, you can avoid the retropulsion. Number two, there are multiple ways you can also pass the jelly behind the stone. You can you can use the basket, Dormia basket, to avoid the retropulsion.
And also raise the head side of
That side and advice.
and costly ways to use a basket to prevent it, but that is little. But cost effective measures are use less pressure of the fluid and raise the head side. So these both can help propulsion.
Among lasers, holmium YAG laser is the most commonly used. It can be used for kidney, ureter, and bladder. There should be direct contact with the stone. Photothermal energy transferably heat and disintegrates the stone, producing fine fragments. The tissue effects is thermal energy can be to a depth of 0.5 to 1 millimeter. The advantage of holmium YAG laser is it is flexible enough to reach the lower pole. It creates the smallest fragments, works compositions, and can be used for non-stone indications. For disadvantages, it has mucosal injuries with 0.5 to 1 millimeter depth of penetration. Fiber breakage can damage flexible scope, and it has high cost. The probe sizes vary from 200 micrometer, 365, 550, and 1000 micrometer. The In a combination, there is ultrasonic and pneumatic are combined together. It cannot be done, but it can be used for kidney and bladder. There should be direct contact with the stone, and mechanism of action is simultaneous pneumatic and ultrasonic both are used together to operate this. Tissue effect is subepithelial denudation, muscularis rupture, and advantages of this combined approach is it is more efficient than pneumatic or ultrasonic alone. It works on all stone compositions, and disadvantages is that it is worked on only rigid probe available, and it requires larger diameter working channel. The probe sizes vary from 9.9 and 11.25.
Time is up, wrap up.
Okay. So briefly, whatever I explain in the chart is written on all these slides. Electrohydraulic lithotripsy, other than renal, can be used for biliary and pancreatic. The mechanism of action is the same that I mentioned.
Summarize.
Summarize them. So these are ultrasonic and laser. These are types of laser which include neodymium, yttrium, aluminum garnet, potassium titanyl phosphate, lithium triborate, holmium, thulium, and carbon dioxide diode. This holmium is what I mentioned. And the type of dual modality lithotripters include lithoclast ultra and cyber bond and shock pulse IC.
Thank you very much. Thank you very much.
One point regarding holmium laser disintegration of the stone is holmium is absorbed by water. This is the best modality for stone management, because every structure is made with water molecules, like they are made in a crystalline structure, and water is used to make their crystalline structure, and stone crystalline structure will be disintegrated with holmium laser. Not only the heat, but its potential to be absorbed with water and cause disintegration of that crystalline structures will cause the stone to become dissolved in that urine. This is the basic mechanism of holmium laser on stone.
Thank you.
Thank
Thank you
you.
very much.